we're going to be talking about meningitis. So what exactly are the types of meningitis? What are the causes? What is meningitis? All right, so itis, inflammation, of course, and meninges. So the meninges is like in a different, so think of like the dura mater, the arachnoid mater, and then the pia mater. Okay, so think of a D, and the D goes up, the lowercase d. So it goes up, so it's the first one. P goes down, so it's the lowest one, and arachnoid's in the middle. So just understand that, and that's got it down. So it goes D for and you want it to be more durable on the outside. So dura for durable, and P is more pliable. That's a way to think about it. So the main two causes that I learned in class for meningitis would be the viral and the bacterial. However, there can be other reasons that your meninges get inflamed. So because of that, there could be a traumatic brain injury, there could be many other reasons out there, and I want you to be aware that bacterial and viral aren't the only ones. However, it's important to be able to differentiate between viral and bacterial meningitis. And the reason is because one is way more severe and way more of an emergency. If we're seeing a bacterial meningitis, this is like 911. This is emergency. Ding, 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 ding. Okay, so basically I'm saying you need to know this, you need to figure this out, and blah, 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 blah. You get the point. So I just wanted to say, so what are like some of the types, the culprit factors to get us like into this groove and to understand what's going on. And also for references, if you want to follow along, I used the Lewis textbook, and it's on chapter 57. It's called intracranial pressure. So all intracranial type stuff is in this chapter. So it just is toward the end of that chapter for a type of problem that can be related to increased intracranial pressure. And it's on page 1381 in my textbook, but it may be something different if it's a different edition and all that. So as we discussed, inflammation of the meninges of the brain and the spinal cord, so all of that. So what are our viral causes and what are the culprit factors going back to that? Enteroviruses, arboreoviruses, HIV, herpes simplex virus, enterovirus most often spread through direct contact with respiratory secretions. So those are just the basic types. It's not as severe as bacterial, and that's why we're going to talk about some bacterial types. So the bacterial kind, you want to think of septic meningitis. It's caused by bacteria, 911. So if you see this, the septic meningitis, bacteria, 911. So Streptococcus pneumonia and Neisseria meningitis are the most common. However, Haemophilus influenza, this has been decreased over the years, thank God, Baruch Hashem, because there has been a vaccine for this, basically. So, yes, this has decreased, so thank God. Now, other things to consider is it enters through the upper respiratory tract, a lot of these little bacteria guys, or the bloodstream, or direct extension of penetrating wounds. So you have an open wound in the skull, fracture of the basilar skull, which is really dangerous. But a lot of them is just upper respiratory tract infections that enter the bloodstream. So things just to think about and be cautious for is if they're having a bacterial to avoid this complication. And if this complication occurred, this is an emergency and this is a problem. So just be aware of that. Now, also, it's important to know your risk factors if you want to do primary precautions as a nurse. So it's more common in the fall and the winter, the early spring, which would be often the secondary to the viral infection, respiratory disease. So, yeah. Now, this is common. I just want to make it there's a ton of reasons that it could be, but the one that you really want to focus on as a nurse and what you're going to preach is they should definitely be getting their vaccines, and because college campuses, nursing homes, prisons. So anytime people are really clustered together and they're close together, you want to think about making sure they have those vaccines. As they say, there's one for 55 years and older, and there's one for those right before they become college students. Your 11 to 18-year-olds having those 2 doses. So 11 to 12, I'm pretty sure. Let's check real quick. For the children, the kiddos, it's 11 to 12. As I said before, and their booster shot is at 16, but it could be anywhere from that range of 11 to 18 years old. So that's the MCV, C for children. And the MPSV is for parents, P for parents, and that would be more than 55 years old. So these are vaccinations for primary precautions to avoid having this in the first place. Now, however, there are signs if you do get meningitis and what you would see if you had meningitis. So let's talk about the clinical manifestations, like what we're going to see our patient have, and then how are we going to have a true, like something more tangible and objective for diagnostics. Okay? So, okay, I'm going to classify this a little bit differently, like viral versus bacterial. Then I'm going to say the two positive sign, like specific, like special things. And then I'm going to kind of differentiate the age groups. So I'm going to do this clinical manifestations in like different parts. Okay, so viral meningitis, as we know, viral is less severe. You're going to see your severe your headaches, your fever, photophobia, stiff neck, which is also called Nuchal, rigidity. So the fever is like moderate to high. So viral is not as severe. Bacterial is a medical emergency. Also, we can see this meningococcal rash, which I see under bacterial. I'm not sure 100% the differences, but it's very clear that bacteria is way more severe from our textbook. So you're going to be looking for like 5% of people with meningitis get that seizure, which is another exemplar. So when if you understand seizures as a concept separately, then you just know that it's the same precautions. So you have to just know that exemplar, which is good because we have both at the same time. All right. Other things are signs of ICP, which is another exemplar, intracranial pressure. So you want to make sure to study that really well so you know how to also treat a patient with increased intracranial pressure. Severe headaches. Now, severe headaches are very like specific. It's progressively worse and it's accompanied by nausea and vomiting. So it's worsening. It's not getting better and there's nothing that like relieves this pressure in the head. Also a fever, nausea and vomiting, irritability. Now, what the really clinical sign is like nuchal rigidity, meningococcal rash. Now, what does this rash look like? It's petechiae, that pinpoint bruising look. Photophobia as the other one, and decreased level of consciousness, and cranial nerve dysfunction. So cranial nerves can be infected in different ways. So you want to think of cranial nerve dysfunction. They could be having a herniation. Cushing triad can happen, which is we also know because of increased intracranial pressure. So that's with that. So you also want to see your meningococcal rash, which is very interesting. All right, so now we're going to differentiate between the older, the children, and the neonate. So we are going to see differences in how are we going to respond to know that this is meningitis. How are we going to actually know as a nurse, like, they definitely have meningitis, we need to do something about it, recommend to the doctor to have that blood culture, get them in the respiratory precautions, all that stuff. All right, so this is what we're going to see for our neonates, our little ones. They're going to have a poor cry, so it's going to be like a weak cry. They're going to refuse to feed, or they'll have poor feeding, so one or the other. Muscle flaccicity, so they're going to be like flaccid. Listlessness, and think about this, the bulging anterior fontanelle, right here, the little diamond thing, bulging anterior fontanelle. Don't forget this. And then remember that neck tenderness right here. They may feel tender. So neonates. Now, what's our difference with the children? So children are a little bit older. They have more of a personality. You may see a behavior change in these children. Seizures may happen. Refusal to eat, just like the other one. Arching of the back and neck, and blank stares. Which blank stares you may think of absent seizures. And with our older patients, you don't want to think about like geriatrics community. You may want to think about confusion. So that may be something different than the other populations. But they all can have some sense of cranial dysfunction. All right. So now here's the two signs that are really unique. So positive Kerning sign and positive Brudzinski. I think he's a Jewish guy. Brudzinski? That sounds... Okay, it doesn't matter. But the point is Brudzinski. Kerning and Brudzinski. So positive Kerning sign means you basically lay them flat. So think of your back flat. Your knees are going up and they can't extend them. So, okay. So think about it. You're laying flat. You're going to have your knees raised. And it's going to be painful to extend. So the patient's not going to extend their legs. So positive Kerning sign is the knee bending, one. positive Brudzinski sign, you're going to basically flex bend their neck, and their hips, they're going to have a back rigidity. Their hips are going to bend, and also I gotta YouTube that a little bit, but their hips and their knees also bend up. So that's the other one. I'm gonna do some more research on that. But Kernig's and Brudzinski. Brudzinski is where you flex the neck up, though. The neck, the knees, the hips, everything gets flexed, I guess. Okay, so let's keep talking. So, viruses versus bacteria. Okay, so viruses, we're going to do a PCR. Why are we going to do a PCR? This is a polymerase chain reaction. This one will tell us if it's a virus. There's a thing called Expert EV, a CSF Lumbar Puncture, which both do. But the CSF, what you're going to see in that lumbar puncture, it's supposed to be clear, but it may be cloudy in this case, cloudy, pinkish, if you see protein in there, things like that. So both of them you can do a lumbar puncture. The problem is you have to do it after CT scan is done to rule out any obstruction in the foramen magnum. So you got to make sure that you get the CT scan before you do the lumbar puncture. All right, you may do a cranial nerve test, so checking all those nerves 1 through 12. I'm going to make sure I know those. So don't forget, look over your cranial nerves. I have them more understood in the other sections, so I'm going to go over that with the other exemplars. But make sure you have to know your cranial nerves for this, because you're like, for instance, like your oculomotor, cranial nerve 3, or number 2, your optic nerve, or number 5 is your trigeminal, number 7 is your facial. So all of those, you have to be like monitoring those cranial nerves. One of them may not be functioning correctly. Okay. So then you want a CT scan, as we discussed earlier. It could be normal and uncomplicated. In others, it may reveal increased intracranial pressure, hydrocephalus. This can cause hydrocephalus because the bacteria can increase fluid production. So you want to make sure that you get a CT scan before you do a lumbar puncture. You want to do blood culture to check if it is bacteria. So if it's bacteria, protein tends to be elevated and glucose tends to be decreased in your CSF, which is interesting. You may do a gram stain for these bacteria. Okay, so sputum, you can get the cultures different ways. You can get it through sputum, nasopharyngeal, the cerebral spinal fluid. So you're going to see it being turbid, purulent, neutrophils. The main type is white blood cells. All right. Okay. All right. So now I think the best thing to do would be to talk about what are complications of meningitis. Like, what are they? What exactly would be a complication of meningitis? Okay. So some complications that we want to think about is like, I was looking at a YouTube, and the main ones that he said was seizures, which is an exemplar, Cushing triad, which is kind of like part of ICP, and sepsis. So we're talking about major problems in the bloodstream. So those 3 things you want to think about and monitor for. For older considerations, you may want to think about their sensory deficits like communication. They may not be not wanting to take pain medications for knowledge deficits, fluid and electrolyte balances, and they're more fragile. They can become critically ill more quickly, and they're on more medication, so drug-drug interactions, stuff like that. Okay, so increased intracranial pressure can cause your altered mental status, residual. Okay, so here I have all the cranial nerves, and I may want to just discuss that right now. So I don't have all of them, but I have the main ones that were on a PowerPoint, and I like to talk about them. So optic nerve 2, what are you going to see with optic nerve 2? Optic nerve 2, you're going to see blindness or papilledema. Let me say it one more time. Optic nerve 2, your eyes. If you ever seen that picture where it does all the numbers, it's really cool. Okay, so optic nerve 2, blindness or papilledema. So papilledema is just edema in your eyes. Oculomotor 3, trochlear 4, abductions 6. All of those you can see ptosis, which is unequal pupils, diplopia. So you want to think of that diplopia, double vision, the ptosis, unequal pupils, all of that was with the 3 that have to do with your the muscles of the eye. Facial nerve 7, you can have paralysis. So like I said, facial nerve 7, paralysis. Trigeminal 5 that's where you have sensory losses. So the facial nerve 7 has more to do with the motor, and they're talking about trigeminal 5 is more of like a sensory thing. Sensory losses, the loss of corneal reflex is to your face, because it goes like 5. The vestibular coccular, number 8. Tinnitus, vertigo, deafness. We're thinking of our ears. Tinnitus, ears, vertigo, dizziness, and maybe they can't hear. It's a problem. All right. What's the other things that we want to consider is hemiparesis, hemonopsia, dysphagia. These can resolve over time if not a cerebral abscess. Now, cerebral abscess can happen, and then there's long-term complications, subdural epemia, subdural effusion, persistent meningitis is suspected if any of these happen. So you may see it could cause problems in the motor. So it really can affect anything. It's the overall topic of that one of complications would be called residual neurologic dysfunction. Now, acute cerebral edema, that can happen. They're basically saying like acute cerebral edema is really like basically hydrocephalus. Headache for months, persistent. There could be non-communicating hydrocephalus. Okay, so there's something interesting that like pops out to me. There's this thing called Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome. All right, so this looks like, I was going to look this up because I thought it was pretty cool. Petechiae disseminated in coagulation. Okay, we'll figure out. DIC. Adrenal hemorrhage, circulatory collapse. So all of that, petechiae, DIC, adrenal hemorrhage, circulatory collapse. So all of that is called the Waterhouse-Friderichsen. I was going to look that up. Okay. So that's our complications. How are we going to treat this patient? So the first thing we want to do, don't forget this, first thing, respiratory droplet precautions for meningococcal. So respiratory droplet precautions until you are sure that it is not a bacterial infection. And this is going to have to be, they're on precautions for 24 hours because I saw a test question that said like how long and 24 hours after being on antibiotics. So first thing you want to do if you suspect meningitis is respiratory precautions. And it's probably the first action too. Okay, so if you find out it's a virus and you find out it's not a bacteria, they don't have to be on precautions anymore. You're going to treat them symptomatically for this. Yeah, basically. It's basically not, you can't give them antibiotics at that point. But initially you can give antibiotics. So you basically test the CSF and then you give antibiotics before you even get the results, which is interesting because I didn't realize that before I learned about it. So you give them the antibiotics until proven not, basically. Until proven they're not a bacteria, you're giving those antibiotics right away because it can deteriorate very quickly. Okay. Let's talk about the nursing care. So the nursing care, we're going to be monitoring things. I wanted to talk about vital signs, neurologic status. Remember, we talked about our cranial nerves, all the different cranial nerves and what we're going to be looking for, the fluid intake and output. You want to see their perfusion when it comes to the urinary. You want to look at their skin because remember that petechiae meningococcal rash. You want to look for the Waterhouse-Friderichsen syndrome and their lung function because it can affect the base of their skull and it can cause problems, neurologic problems. Fever. So what do you want to do? You want to have fever, you want to reduce the seizure risk because anytime you increase the body heat, anytime you increase the body heat, you are increasing the risk for seizures. So acetaminophen, aspirin, things that are antipyretics, you may want to give them a cooling blanket. However, there's always a however, but you need to avoid them shivering because this can result in a rebound effect. But also, there's also tepid sponge baths if that is not available, the cooling blanket. So just remember, you don't want them to shiver. It's very subtly in there, in the PowerPoint. Okay, so after that, talked about seizure precautions with antipyretics also. But if they do have a seizure, you're going to have to do implementations for that, like the pillow to protect them. That's a whole exemplar in itself that I'll discuss. Okay, dehydration and reducing stimulation. So that's everything for that. Now we have to talk about home care, pharmacology, and vaccines. Let's talk about pharmacology. How are we going to act in the hospital before we start saying how we're going to send them home? That would make sense. Okay, so pharmacology, phenytoin, that's just okay, so that's just for anti-seizure. For prophylaxis, there's also dexamethasone. That's a glucocorticoid that just will reduce inflammation. Inflammation. Antipyretic that will reduce fever. IV fluid that helps with fluid electrolytes. Pain management because they're in a lot of pain with their headaches. Barbiturates. If ICP is more than 20, you may need to sedate them because they may need help with breathing. Antibiotics, you may want to look at the peak and trough values of gentamicin and vancomycin. I was going to go look that up. And mannitol. Why do you want mannitol? So mannitol is, you want to look at their eyes and nose. Oh, mannitol. It's for ICP. That's what it was. I was like, why do we give mannitol again? But I was just like, oh my God, it's an osmotic. Okay. I know. Urine output increases with this, but you want to be cautious because if it's more than like 500 milliliters, it may be diabetes insipidus and there's some neurologic thing going on. So you gotta like just make sure what to look out for. Home care. Okay. So home care is like when they get transferred from the hospital to maybe like a rehabilitation center. Like what are you going to tell that nurse? What do you want to make sure that they come home with, depending who's the caregiver? So depending on how that recovery process goes and how much complications there were with that situation. Make sure they have high protein. They need to help recovering. High calories, small frequent meals, warm baths, progressive range of motion, and appropriate referrals if they need any, especially for like neurologic deficits. So when it comes to vaccines, we talked about this a little bit, but the MPSV is more than 55 years old. The MCV is children below 55. There's 2 dosages, 11 to 12 years, and the 16 years for the booster shot. Vaccinations from respiratory vaccines is pneumonia and influenza. So vaccines from respiratory vaccines, pneumonia. Oh yeah, they're just saying like to avoid having other problems besides the meningitis specific ones. So prophylactic for anyone exposed to meningitis has prophylactic medication, antibiotics given to them, and medications for if you have meningitis to prevent the spread to the or medications just for a respiratory infection to prevent from the meninges. Okay. So overall, that's everything I have. I'm just thinking of what I need to review. I'm going to be looking over the 2 main signs of the Kernig's and the Brudzinski's. I think that was the main thing, and the Waterhouse-Friderichsen syndrome. So those are the things that I need to look over that were very different. Everything else I feel very confident about. So that was meningitis. Hope this helps, and happy studying.